Alrighty. Hello, everyone. I'd like to welcome you all to the poster discussion session on pancreatic tumors. We have 9 short presentations within this session. If you have any questions, please enter them into the chat and we'll do our best to address them within the tight time schedule. My name's Ryan Barron. I'm a pancreatic surgeon from Liverpool in the UK, and I'll allow my co-chair to introduce themselves now.
Good day to everyone. I'm glad to see all of you here in the European Pancreatic Club in Kiev, Ukraine. I'm from Ukraine, Professor Alexander Rotor. We are working in the general surgery department and making research and surgery for pancreatic different kind of disease.
Okay, so to open this session, I'd like to introduce our first talk by Mikhail Stasiak on the diagnostic and prognostic value of apelin and serum amyloid A3 adipocytokine measurement in patients with pancreatic ductal adenocarcinoma compared to chronic pancreatitis and healthy subjects. This is from the Medical University of Lodz, Poland.
Hello, thank you for the invitation for this EPC meeting. The aim of our study was to search the diagnostic and prognostic value of serum amyloid A3 and apelin adipocytokines. The study group included 65 patients, 34 with pancreatic ductal adenocarcinoma, 11 with chronic pancreatitis, and 20 healthy subjects that were the control group. Our results show that the serum mean of apelin concentration level was significantly higher in chronic pancreatitis compared to pancreatic cancer. On the other hand, the patients with pancreatic cancer had significantly higher mean of serum amyloid A3 level than those with chronic pancreatitis. We also compared patients with metastasis and without metastasis from the pancreatic cancer group, and in pancreatic cancer group without metastasis, mean serum level of apelin was significantly higher compared to patients with metastasis, and on the other hand, mean of serum amyloid A3 was significantly higher in the metastatic group rather than without metastasis. To conclude, apelin and serum amyloid A3 may represent the possible biomarkers for pancreatic cancer and chronic pancreatitis. Apelin, but not serum amyloid A3, expression seems to be stronger in pancreatic inflammation than in malignancy. So taking into account, these proteins may be potentially useful in pancreatic cancer and chronic pancreatitis differentiation. What further studies are needed? Thank you very much.
Thank you very much for this opening talk. We'll keep an eye on the chat. If I could just ask if you have any hypothesis to why you think the apelin goes up in pancreatic tumors and then reduces with metastatic disease.
I think he is muted. Michal, switch on your microphone, please.
Okay. I think we're having a slight technical issue. So in the interest of time, let's move on to our second talk. I'll allow my co-chair to introduce.
Okay, our second presentation is called the bile-evaluative organic compounds in diagnostic of pancreatic cancer and biliary obstruction, a prospective proof of concept study presented by Ville Teranen from Finland.
Dear Chair, dear colleagues, thank you for the opportunity to present our data today. My name is Ville Teranen, I come from Finland, and here are the members of our study group. Our study topic is bile-volatile organic compounds in the diagnostics of pancreatic cancer and biliary obstruction, a prospective proof of concept study. So from my personal background, I'm MD, currently working on my doctoral dissertation in GI surgery. We have no relevant financial relationships to disclose. First of all, volatile organic compounds are easily evaporated molecules from bodily fluids such as urine and can work as chemical fingerprints for certain diseases. However, only one study has been published about bile walks. We obtained bile sample from 94 patients during ERCP in Tampere University Hospital. We analyzed the samples using Lone Star chemical analyzer by Oldstone. Here on the left, you can see the categorizations and number of patients in each group. Our primary objective was to differentiate pancreatic cancer patients from acute and chronic pancreatitis. As secondary objective, we aim to differentiate all pancreatic region cancers from all kinds of benign causes of biliary obstruction. Statistical analysis was done by a statistician, and machine learning methods were utilized, and results were also cross-validated. Here are visualizations of our analyzer output molecules constituting specific smear print for certain disease can be found between these two spikes. Our results were quite good as sensitivity and specificity to detect pancreatic cancer from pancreatitis were excellent, and also correct rate was 88%. Results were lesser in secondary objective, but correct rate was still over 80%. So conclusion is that PileVox shows promising capability in detection of pancreatic cancer. In future, this method could offer a new supportive method for clinical practice. Thank you for your attention. I'm happy to take any questions now.
Thank you, Willie. We're waiting for Baron. I'm not seeing question in chart.
Hello.
Yes.
So it's interesting from a radiological perspective. It can be difficult to differentiate between different types of tumor. Would you? So that puts us in the second group, which had the lower sensitivity. Are there any ways that you think this technique could be improved to improve the sensitivity within the all-comer group?
That's something we will work on in the future, and it's hard to say at this point where this project goes, but we are currently working on multi-center trial and planning to more deeply dig into this topic.
Thank you very much.
One more question, may I?
Yep.
As I understand, the word organic compounds is a common name. What exact kind of them do you think participate in the cancer development and occurs more highly concentration?
So you are asking which specific
of them?
box?
Yes.
There are some hypotheses about this currently, but the exact molecules are a bit unknown. One thing that is known at this point is that one specific kind are linked, and I'm discussing about that deeply in article that's going to be published soon. But
okay.
That's at this point something we don't know.
Okay, thank you.
Thank you very much. So our third talk is by Andrei Komiak from the University of Colorado on survival outcomes of pancreatic tumors in pediatric population, analysis of Ncdb and Seer databases.
Dear colleagues, I'm grateful for the chance to present our work on survival outcomes of pancreatic tumors in pediatric population. My name is Andrei Komiak. I'm a general surgery resident in University of Colorado in Denver. I have no financial disclosures to make. Despite the increased incidence, there are few data published to describe pancreatic neoplasm in children, with some reports suggesting a different behavior of certain tumor subtypes compared to adults. While in adults, malignant neoplasms of the pancreas are mostly comprised of pancreatic ductal adenocarcinoma, there is far more variety in tumor histology in the pediatric population, resulting in diverse clinical presentation and prognosis. So the aim of our study was to describe cases of pancreatic tumors in children with corresponding survival outcomes. We extracted pediatric cases less than 18 years old between 2004 and 2018 from a dual source National Cancer Database and Seer. We collected and analyzed patient demographics, clinical presentations, surgical treatment, chemotherapy, oncological features, and 5-year survival. A total of 215 and 99 children with pancreatic tumors were identified in Ncdb and Seer databases, respectively. There were 63.7 and 72.7 females with median age at the time of the diagnosis of 14 and 13 years. The most common lesion identified were solid pseudopapillary neoplasm, occurring in 42.8 and 49.5% cases. Adenocarcinomas were identified in 9.3 and 5.1% of cases. Surgical treatment was performed in most cases, with pancreatoduodenectomies being the most common procedure at 33.1% and 36.4%. Survival curves are shown on the graph for Ncdb database. Among those in Ncdb, best 5-year survival was 96.8% for SPN, 84.3% for neuroendocrine tumor. 47.3% of survival was recorded for carcinomas, pancreatic carcinomas. Similar findings were noted in the Seer database. From a sub-analysis, though, conducted using the Ncdb dataset, among carcinomas, PDEC presented only 33 5-year survival, whilst other histologies presented with 57.1 5-year survival. This data suggests prognosis of children with pancreatic tumors may be better than that of the adult population. Among pancreatic carcinomas, PDAC has significantly worse 5-year survival, which is consistent and similar to that in adult population. Thank you for your kind attention.
Thank you very much for that presentation. I think we do have Andrei Komiak with us at the moment now. Could I just ask, as you pointed out, the frequency of tumors in children is very different than the frequency in adults, with the most common tumor being solid pseudopapillary neoplasm compared with adenocarcinoma in adults. Have you compared tumor like tumor types to look at survival differences between children and adults, rather than the whole group?
Thank you for the question. I just wanted to understand it better. So you're asking if I compared
just the adenocarcinomas with adenocarcinomas, neuroendocrine with neuroendocrine, solid pseudopapillary with solid pseudopapillary, which is obviously much rarer in adults.
Yeah, we have not made the comparison between the adult and pediatric population directly. So it was only to analyze the pediatric population itself, because there were some reports suggesting that like PDEC and pediatric population have as high of the survival at 5 years as like 50%. And that basically just because many analyses included a cohort with patients from like some other types of carcinomas, not just PDAC.
Thank you.
Thank you. Nice
Thank
work.
you.
Should we move on to our next topic?
Yes, next topic, next report is presented for the common work. It is not necessary to resect almost cystic neoplasm of the pancreas. Current guidelines do not reflect the actual risk of malignancy. A systemic review and meta-analysis presented by Tommaso Pollini. This is a common work from University of Verona, University of Foggia, and San Francisco.
Good afternoon, everyone, and thank you to the EPC for giving me the opportunity to present this study. My name is Tommaso Pollini, and I am a PGY-5 general surgery resident in Verona. I have no disclosure to make. So mucinous neoplasm account to 25% of resected cysts, and they generally affect women in their 50s and are located in the pancreatic body tail. Regardless of their incidence, we asked ourselves, what is the incidence of malignancy in those lesions, and are we overtreating them? So we performed a systematic review of over 2,000 studies, and we included 40 studies in the final meta-analysis for a total of 3,200 resected mucinous neoplasm. And in these patients, we found that the pooled rate of malignancy was 16%. We then assessed the role of size and mural nodule, and we found that size indeed is associated with malignancy, with malignant lesions being bigger than benign lesions, and that a threshold of 65 millimeter was the best to predict malignancy in these tumors. We also confirmed that mural nodules are actually associated with malignancy with an odd ratio of 4.3. And summarizing my results, these tumors affect young women and are generally resectable with a minimally invasive approach. And we know that these tumors have the potential to progress to pancreatic cancer. However, we also know that in 2012, the international guidelines reported similar rate of malignancy for branch duct IPMN. However, after those report, we worked relentlessly to identify a subgroup of patients, branch duct IPMNs, that were candidate to surveillance. So in conclusion, we found that the pool rate of malignancy in resected MCN was just 16%, and we confirmed the role of neuronodule and size. However, we think that surgery, the role of surgery from using cystic neoplasm should be probably reframed in the context of a cancer prevention strategy. Thank you very much for your attention.
Thank you for your report.
Could I just quickly ask, did you look at rate of growth of tumors under surveillance, or just the actual size when they reach that threshold of 65 millimeters?
So thank you for your question. Yeah, so it was not possible to see growth rate as we look at published papers which did not report initial and final sizes. So we were only able to see to assess the implication of sizes at the time of surgery. Although we know that for the future, as we did for branch duct IPMN, we should look also at growth rate. Yeah.
Thank you.
Thank you.
Thank you so much.
Nice report.
Our next presentation is Giulio Belfiore on the very early recurrence after R0 and R1 resections for pancreatic ductal adenocarcinoma, proof of concept for a biological R2 definition from the IRCCS San Raffaele Scientific Institute, Milan.
Good morning, and thanks to APC for giving the opportunity to discuss our work, very early recurrence after A0 and 1 resection for pancreatic ductal adenocarcinoma. Proof of concept for a biological R2 definition. I am Giulio Belfiore and I'm a pancreatic surgeon and I work in San Raffaele Hospital and I have nothing to disclose. Aim of the study was to evaluate the group of patients that develop a very early recurrence within 12 weeks after surgery. This group was defined as biological R2. We enrolled all patients that underwent a surgical resection with radical intent between 2015 and 2019 in our institution. Independent predictors of very early recurrence were searched in the entire cohort, and then we split the analysis in neoadjuvant and upfront treated patients. Among 573 patients included in the study, 63, 11%, were classified as biologic R2. The percentage of neoadjuvant treated patients in this population was equal to all other patients, and median DFS of the entire population was 17 months. Independent predictors of being a biological R2 were body tail site lesion, higher TNM, higher grading G3, and high lymph node ratio. Below you can see all other factors that were considered. Concluding, about 11% of patients with a potentially resectable duct experience a very early relapse after surgical resection. Neoadjuvant treatment may not influence the selection of this population. A detailed and accurate understanding of this BR2 population is necessary in order to avoid a potentially inappropriate surgery. Thank you.
Thank you very much for that very interesting presentation. This is something we all worry about, the biological disease. I'd be interested to know, in terms of avoiding inappropriate surgery, two of your markers, the grade and the lymph node ratio, can only be determined post-operatively. How would you suggest taking this forward to try and identify a strategy for avoiding inappropriate surgery?
Thank you very much for your question. To say that the only preoperative marker of this is the body tail lesion that we know that have potentially a more aggressive disease, biologic aggressive disease. So in body tail lesion, we should always consider potentially a neoadjuvant treatment if even if it's resectable. Talking about lymph node ratio and grading, there are some indirect signs of which we can deduce that there is a high grading. For example, a necrosis inside the lesion. So in hypodense sign at CT scan, or maybe grading can be determined at cytology sometimes. But I think that all these are not so useful in all-day practice. I think that we should take this work only as suggestion to concentrate to this population of 10% that is similar to the population of 10% that has a long-term survival. So we have these two population, 10% early recurrence, 10% long-term survival, that we need to study better of biological markers. So we have to identify maybe something that is more in their mutations, mutational status, and etc.
Thank you very much.
Thank you very much. The next presentation is called Heat Shock Protein 90, Target Structure in Acute Pancreatitis and Pancreatic Ductal Adenocarcinoma, the common work from the United States of America, New York, and Lithuania, Vilnius, presented by Aiste Kelete-Gulia.
Hi, ladies and gentlemen. My name is Dr. Gala from Vilnius University Hospital, as well as presenting at the Georgetown University Hospital in Washington, D.C., United States. Thank you for the opportunity to present, and today is my topic on heat shock protein 90 as a target structure in acute pancreatitis as well as pancreatic ductal adenocarcinoma. As we all know, pancreatic ductal adenocarcinoma is one of the deadliest cancers for the very few curative therapies available to date. Acute pancreatitis is a kind of a rare manifestation of a PDAC causing high morbidity and mortality depending on the severity of the disease. Heat shock proteins were selected as important protection agents against the cell stress and inflammation, and inducible heat shock protein 90 is quite important in the process. So our aim was to determine whether HSP90 elevation during acute pancreatitis course can lead to development of the PDAC. We had 50 patients in acute pancreatitis group, as well as 48 patients in PDAC. Peripheral blood was collected from both of the cohorts. ELISA tests were done. As you can see here in the results, it's nicely certification in both of the groups. In acute pancreatitis patients, HSP90 levels are higher than the PDAC. And then when we look at the Kaplan-Meier stratified by the HSP90 class, you can see that the survival, the lower the score, the survival is higher, adjusted by the depth, as well as in the same group. So in the figure 4, you can actually really see quite a nice distribution here between the gender, race, and pancreatitis treatment. In conclusion, the high serum levels of HSP90 may be a risk factor and independent prognostic indicator for tumorigenesis in pancreatic ductal adenocarcinoma. Thank you for your attention. I'll be happy to answer any questions.
Thank you very much.
In terms of correlating higher levels with tumors, I assume the graphs, the survival plots were just for the cancer group rather than the pancreatitis patients included. Do you see any causative role of HSP90? We can't assume that correlation and causation are linked.
Yes, I do. And actually, we have the current experiments going with the correlation as well between the cancer and pancreatitis. So I think it's going to be interesting and exciting work coming up.
We look forward to seeing that. Thank you.
Thanks so much.
So our next talk is from Ottavia De Simeoni, the immune microenvironment in pancreatic ductal adenocarcinoma, a potential preoperative marker of lymph nodal involvement. This is from the Veneto Institute of Oncology, Italy.
Good morning, everyone. I'm really thankful for the opportunity to present our study. I am Ottavia De Simeoni. I'm a general surgeon at the Veneto Oncologic Institute. Our study analyzed the potential role of tumor microenvironment as predictor of lymph nodal involvement in patients with pancreatic cancer. Aim of this study was to analyze potential immune marker expressed by TME as potential preparative predictor of lymph node involvement. We analyzed 38 patients undergone curative surgery for pancreatic cancer. All patients have diagnosis of resectable pancreatic cancer. Immunohistochemical analysis was performed in order to characterize the TME of each patient. 81% of patients analyzed had lymph nodal involvement at the pathological analysis. As shown in the figure, lower expression of PD-L1 and intraepithelial CD3 can be considered good predictor of lymph nodal involvement. Lower expression of PD-L1 and intraepithelial CD3 had a negative predictor value of 36% and 28% respectively. Lower level of CA-99 and the radiological analysis has a negative predictor value of lymph nodal involvement of 31% and 21% respectively. The association of CA-99 and PD-L1 or intraepithelial CD3 reached a negative predictor value of 15% and 66% respectively. In conclusion, TME data empowered the negative predictor value of biochemical and radiological analysis in lymph nodal status assessment, increasing their preparative value. TME could be considered as potential preparative immunomarker of staging in order to make the best therapeutic choice. Thank you for your attention.
Thank you very much for your interesting presentation. Do you think there's a role where we could look at these markers on biopsies to preoperatively estimate the lymph node involvement, and what do you think the role will change management in that setting?
Yes, it will be interesting to perform this analysis on the preparative biopsy, but it's very difficult due to the scarcity of tissue of preparative biopsy. So we needed to identify more stronger markers and do it on the preparative biopsy.
Thank you very much.
Thank you.
Yes, thank you. And the next work is coming from Spain. Integration of serums to an urine metabolomic profiles for pancreatic cancer risk prediction, presented by Francisco Jurado.
Good morning, you all. My name is Francisco Jurado. I'm a PhD student at the Spanish National Cancer Research Center, and I want to thank the organizing committee for selecting my abstract. As you know, pancreatic cancer is projected to become the second most mortal type of cancer by year 2030 if nothing is improved. And even though several risk factors of these illnesses are well identified, those are not enough to define high-risk population. Therefore, our main objective is to construct an integrative predictive risk model based on serum, stool, and urine metabolome features, along with epidemiological data. To achieve that goal, we use the PanGene EU studies with 50 cancer cases and 56 controls that were selected and quantified their metabolome in stool and urine, followed a nuclear magnetic resonance. And for the serum samples, we implemented a liquid and gas chromatography followed by mass spectrometry. Regarding the methodology, a lasso model was used for both feature selection and model fitting, followed by an internal cross-validation. Regarding the result, the beta diversity score of the feces and serum aqueous were the two which displayed the greatest metabolome variance explained by the cancer status feature. A bubble plot is displayed here in the poster, summarizing each metabolome concentration pattern between cases and control. And regarding the predictability, our results prove that the metabolome has a good classification for performance. In particular, the serum gas model yield the largest area under the curve with 0.85. And from the integrative 5 assays, an IUC of 0.81. As a conclusion, first of all, to our knowledge, this is the first study that compares and combines metabolome features from serum, stool, and urine into the pancreatic cancer risk prediction. And secondly, that the predictability of the metabolome was large across the 5 assays, and it is, in particular, the serum gas metabolome reported the largest prediction of pancreatic cancer risk. Thank you very much again. I'm happy to take any questions.
Thank you for your nice presentation. We are waiting for Baron. Okay.
Apologies. I don't have any questions either and haven't seen any on the chat. So in the interest of time, we'll move on to our final presentation. This is from Domenico Tamburino on the dynamics and cost of patients with appropriate too early and too late surgery for low-risk intraductal papillary mucinous neoplasms from the San Rafael Scientific Institute, Milan.
Good morning. Thank you for the opportunity to present this study entitled Dynamics and Costs of Patients with Appropriate Too Early and Too Late Surgery in Low-Risk IPMN. I'm Dr. Domenico Tamburino. I'm consultant surgeon at San Raffaele Hospital, Division of Pancreatic and Transplant Surgery Unit. I have nothing to disclose. The aim of the present study was to evaluate the rate of correct indication for pancreatectomy, defined as high-grade dysplasia in patients who underwent surveillance for a median of 5 years follow-up. Secondary outcome was to evaluate the cost of surveillance. This is a Pancreas 2000 project, enrolling all consecutive patients with a presumed low-risk branch duct IPMN without worrisome feature, with a minimum follow-up of 24 months. As you can see, after the end of follow-up, 7% of patients were operated, 16 patients had the high-grade dysplasia, 16% had the low-grade dysplasia, and 16% in invasive cancer. The mean cost of surveillance was €194 per patient here. The mean cost of surveillance from diagnosis to surgery was €854. As you can see, despite the cost of follow-up in patients who underwent surgery with correct indication was higher compared with the other two groups, the difference is not statistically significant. The conclusion is that there is a high rate of unnecessary surgery and a possible added benefit of closer follow-up, but the cost effectiveness needs to be investigated in a prospective fashion. Thank you very much.
Thank you for your nice presentation.
Thank you very much. That was a nice presentation. As well as the unnecessary surgery in the low-grade dysplasia group, there was also a number of confirmed neoplasms within the group. And fitting with the question from the chat, how would you decide when to resect?
Well, obviously, we decide to resect patients with IPMN only in presence of high-risk stigmata. As you know, we follow the European and international guidelines. So, only in presence of high risk, we decide to go ahead with surgery.
Thank you.
Regarding worrisome feature, you know better than me that we have a lot of discussion regarding relative indication or absolute indication. We think that the worrisome feature remains a relative indication based on patients' outcome. We need to discuss regarding benefit of surgery versus oncological safety.
Okay, it'll be interesting to relook at it with prospectively with more strict guideline following. Thank you.
Thank you very much.
Yep.
Okay, so that concludes this poster discussion session. I'd like to thank all the participants for some fantastic presentations. And I'll see people in the later sessions later today. Thank you very much for attending our session.
Thank you very much. It was very interesting session and very new data we got to this knowledge. Thank you.